All mechanical back pain can be divided into 4 patterns. Pattern 1 is back dominant and therefore referred pain. It is pain felt most intensely in the back, buttock, over the trochanters, into the groin, or down the coccyx. It is pain that may be constant or intermittent. It's the only pattern that gives you that option. And the neurology on examination must be negative because this is referred pain. The physical examination of pattern 1 separates pattern 1 PEP, prone extension positive, from pattern 1 PEN, prone extension negative. Pattern 1 is back dominant pain aggravated on flexion, so my physical examination is to have the patient bend forward and assess whether this reproduces the typical pain. The pattern 1 patient, who is a PEP patient, prone extension positive, will have a relief of his symptoms, either complete abolition or significant reduction within 10 repetitions of the sloppy push-up. The pattern 1 PEN patient will find that the prone extension is too painful to perform or has no effect on the patient's pain. Pattern 1 PEP is a patient with a clear directional preference and therefore easier to treat. Pattern 1 PEN is a patient where flexion and extension are painful, and this patient can be a real challenge. Pattern 2 is always intermittent, and it is never worse on flexion. Any pain on forward bending or a constant pain qualifies that patient as pattern 1. Pattern 2 is a very discrete, very distinct group and easy to treat. The physical examination of pattern 2 will show me a patient whose pain is aggravated on extension but is never made worse on forward bending. The pain is always intermittent, so there will be moments when the patient is without symptoms. Pattern 2, like pattern 1, is referred pain, and therefore the neurological examination will always be negative. Pattern 3 is radicular pain. It is constant leg-dominant pain, and so the physical examination will show a positive neurological test, either an irritative test, such as straight leg raising or femoral stretch, or a conduction loss in L4, L5, or S1. Whatever I find in pattern 3 will support the history of constant leg-dominant pain, and it will be backed up by a positive neurological finding. Pattern 4 indicates intermittent leg-dominant pain. There are 2 entirely separate types, and the physical examination will separate the pattern 4 PEP from the pattern 4 PEN. The pattern 4 PEP will have symptoms aggravated on flexion. So when I ask this patient to bend forward, the leg symptoms will increase. And they will improve on extension, so that doing a sloppy push-up or even lying in an extended position, prone on elbows, for example, will reduce the leg symptoms, the intermittent leg-dominant pain. Pattern 4 PEN is much more common. This is neurogenic claudication, a set of symptoms brought on by walking, which is activity and extension, and relieved by sitting down, which is rest in flexion. So these are patients who are prone extension negative. Extension aggravates their symptoms, and they are relieved as they bend forward. The neurological examination in pattern 4 is highly variable. In pattern 4 PEP, there may be an irritative test, much like pattern 3, and there may be loss of motor, but this is by no means certain. In pattern 4 PEN, neurogenic claudication, there is never an irritative test, but there may be, in some cases, loss of local motor power. Back-dominant pain is far more common than leg-dominant pain. But in the leg-dominant group, pattern 4 PEN, neurogenic claudication, is becoming an increasing problem as our population ages.